Hi, I'm Gregory Katz, Chair Professor at the University of Paris School of Medicine, President of PROM, and Academic Director of the EIT Health Report entitled Implementing Value-Based Healthcare in Europe. The best way to describe the essence of this report is to look at the picture on the left with the bean pod metaphor. Each bean represents a healthcare giver, and you can see on the right side a bean or a caregiver that is outperforming, which means delivering high-value care. The three things which are essential to distinguish this outperformer and also create a driving ecosystem based on patient health gains is first to systematically measure patient outcomes in a standardized manner. It's also about creating a transparent ecosystem where caregivers can compare with each other in a safe environment without the fear of a name and shame game, but rather of a stable, transparent community of learners willing to enter into a peer-to-peer dialogue to drive a learning traction. And lastly, the most important thing is to find a neutral facilitator that not only gathers the data but keeps all the stakeholders sitting at the same table with a common trust in the system, and this is a real organizational challenge. So where do we start in terms of measuring patient outcomes? First, there is a stunning difference in hospital outcomes across Europe. You can see in Germany that there is a 11 times variation in severe incontinence after radical prostatectomy, depending on which hospital or clinic you are treated. In Sweden, in the ophthalmology departments, you have a 30 times variation in capsular complications after cataract surgery, depending on of which team or which clinic you are treated. Well, there is a couple of reactions to this. The first is that, why is it that there's just a handful of flags on this chart? What about Spain, France, Italy? Is it because the health system is so homogeneous and the patient outcomes are so identical that they don't need to show and disclose the variation in health gains? Or is it simply because there's a kind of cultural retardation and they haven't even started to measure and compare patient health gain? The second thing is about the remuneration. Those who have a higher re-intervention rate will generate more revenues than those who deliver high-value care with a low complication rate. This is a consequence of the fee-for-service, which incentivizes a crazy race for volume. And lastly, patients are simply unaware of where to orient themselves in the health system, simply because these outcome benchmarks are unavailable and patients are kept in the dark. So in order to change the system, the value-based healthcare momentum introduces a definition of value, which is the outcomes that matter most to patients relative to the cost to achieve these outcomes. It's an actionable definition simply because we know now that it is absolutely essential to measure and focus on patient outcomes. How? Through outcome indicators and choosing patient-reported outcome measures is actually has strategic implications in terms of choosing a medical team to compare and to learn from. The second thing is the cost. The cost, we discovered through our investigations across 22 EU countries that it's still a black box for payers and a blind spot for hospital managers. Why is that? Because most of the cost accounting systems are designed for billing. The second reason is that there's a clear reluctance from providers to share cost information to ensure that the net profit margin remains confidential and not to enter into tariff negotiations. The third element is that prices, tariffs, and charges varies in very important manner across EU health system. And lastly, there is of course some important approaches such as the time-driven activity-based costing, but this gold standard in terms of cost measurement is considered as rigorous, yet laborious and not scalable by many providers. So let's be honest, in the value equation, the denominator is patient outcomes. It can be measured and standardized and compared across regions and across countries. But the denominator is still a black box, and it's probably where we should improve over time in order to harmonize and standardize comparisons. So, in order to spearhead this effort, we compared 22 EU countries, and we have conducted nearly 250 interviews with VBHC leaders. We have also visited 34 leading organizations in terms of VBHC, and that's a body of empirical knowledge from which we derived a matrix. This implementation matrix is the common denominator of best practices, practical solutions that were brought up by these leaders. We have on this chart 5 dimensions: recording, comparing, rewarding, improving, and partnering. And each of them is divided into building blocks. We have 9 building blocks. The first is condition. So a condition identifies a patient group and a population segment. Then the second thing you need to do to have a successful implementation is really to mobilize a core team of clinical champions, but also patient representatives, and also to get the board support to make sure that this will be a strategic plan for the hospital or the clinic. Then you need to design a scorecard with processes, costs, and of course outcome indicators, but with also a case mix adjustment in order to stratify patient profiles according to the severity and compare apples to apples. This is the ground for a data platform that will enable data capture and interface interactions, and also the springboard for benchmark, internal or external benchmarks. Internal benchmarks within a team, or external benchmarks across different providers and competitors. This requires actually investments, human and financial resources, mostly for designing a data platform or for conducting the project management. It requires also incentives, economic and psychological incentives. Economic with remuneration, and it could be a bundle payment, or also psychological incentives through recognition and reputation. We also need to create an improvement cycle through a learning community and training programs. And lastly, create external alliances and partnerships with payers, with life science companies, with health authorities and scientific bodies. So I will try to go through these 5 dimensions and these building blocks with concrete cases and illustrations. Let's start with recording. You need first to distinguish 2 dimensions or essential component of what we call quality of care. Quality of care implies appropriateness of care and performance of care. Performance addresses the complication rate or reintervention rate, whereas appropriateness addresses the health gain itself, so the clinical benefit in patient daily life. And this distinction is very important because you can perform care without any complication, but also without delivering a positive health gain to the patient. So the absence of complication doesn't necessarily imply that the care is appropriate and beneficial to the patient. Recording also means that there might be significant differences in terms of views about the importance of patient outcomes. In blue, you have for prostate cancer the views of a practitioner in terms of symptoms and patient outcomes. And in red, on the histogram, you have the patient priority in terms of outcomes. And you can see also the significant differences on the histogram for pain, for fatigue, for libido, for diarrhea. So that means that the truth about high-value care is probably in the middle. That means you need to combine the patient view and the practitioner view, and this is why value-based healthcare is actually creating a composite score with clinician-reported outcome measures and patient-reported outcome measures. So the truth is in the middle, and in order to drive this effort to standardize outcome instruments, OECD has launched an initiative named the Patient-Reported Indicator Survey in 2017, and you can see on the right side the picture with the Ministry of Health across OECD countries who actually accepted to work in designing common standards to benchmark health gains for breast cancer or prostate cancer or hip replacement across these countries using the same scorecard. This is of course aligned with what ICHOM is doing with standard sets for each condition, and you can take the example of breast cancer. You can see that most health technology assessment is using until now two classic outcomes in terms of performance of care, which is overall survival or recurrence-free survival in oncology. Yet you have a myriad of other dimensions that really matter to patients, such as depression, pain, fatigue, body image, sexual dysfunction. And these dimensions are integrated through questionnaires, auto-questionnaires, about quality of life in daily activities that patients report. There is also a standardization of collection time points. You have one care pathway without surgery, and there might be for breast cancer a mastectomy, so there's another care pathway with other collection time points. So the main idea is to look at a patient from a care pathway perspective and not from a medical product perspective, such as a drug or a medical device. Drugs and medical devices are part and parcel of the care pathway, but there is also a significant amount of steps and cares that are delivered throughout the care pathway, and the idea is to measure the value of this care pathway as a whole. When patients are recording their outcomes, then these outcomes are discussed during consultations with the practitioner, and this of course strengthens the dialogue and trust between the practitioner and the patient who feels involved in decision making. We measure through this spider chart the health gain, which is the difference between the post and pre-scores that were documented through the PROM instruments. You have here a Dutch example of a colorful PROM instrument where the questionnaire is displayed in different areas, and of course this is more engaging. The response rate for this type of PROM questionnaires is over 95%. So this response rate reflects also the importance or interest of the patients, because now these PROM questionnaires are becoming part and parcel of the care pathway and the therapeutic approaches. So this is why it's important. It's not necessarily the case with patient-reported experience measures, which are completely different from patient-reported outcome measures. Patient-reported experience measures, PREMs, are actually focusing on processes. Processes or organizational procedures such as waiting times, communication with the medical team, cleanness of the room, or also the quality of food in a hospital. Well, this is of course something important, but health gains and patient outcomes is the sheer reason why patients are seeking care. And in terms of priority, it's really important to remember that PREMs are definitely not part of the value equation, which is again outcomes relative to the cost. There's a kind of confusion today about PREMs and PROMs simply because they have nearly the same acronym. Both are patient-reported, but they are not twin brothers. It comes from a kind of confusion between hospital and hotels. Actually, the TripAdvisor star rating system doesn't apply here, simply because a good hotel is a place where you wish to come back. A good hospital is a place where you don't need to come back. So the scorecard, you have in the Netherlands, Santean is a group of 6 teaching hospitals who adopted the same standardized scorecard with outcome indicators, cost, processes, and treatment mix. And they benchmarked the care pathways. The process mapping of the care pathways, for example, for brachytherapy is described here. You have in the dark circles the number of minutes for each single step of the care pathway. And when you correlate the number of minutes with the caregiver in charge of this care, you can multiply the number of minutes and get a full picture of the cost associated with each step and ultimately with the entire care pathway. This is the TDABC approach for custom measurement. We found in Sweden at Uppsala Academic Hospital a great tool in the maternity unit where you can also stratify the population and create a risk adjustment tool. You have on this wheel segments and sub-segments of the population or the active file of patients which are treated, so you can really target and isolate the patients that require most attention in order to deliver high-value care. For the second dimension, comparing, there is also a distinction between the learning community and transparent benchmark. Learning community requires improvement cycles. Plan, do, study, act, whereas transparent benchmark requires a safe environment with internal and external comparisons. External comparisons, there's a clear illustration with a health at a glance published by OECD last year, where for the first time you had a nominative benchmark of providers, hospitals, such as the US Memorial Sloan Kettering Cancer Center, comparing with Charité or with some hospitals in France, Australia, Sweden. And that's a significant improvement since they are using the same scorecard, the same PROM instrument for breast cancer. Coming back to Santea, you can see here that they have launched internal benchmark that generated after just 18 months significant improvements in terms of complication rates. San Antonio's, for instance, dropped its complication rate by 250% in only 1.5 years. And this is a direct consequence of comparing each other's figures through a standardized methodology and nominative benchmarks. Spire in the UK is a group of private hospitals who chose to also benchmark for hip replacement patient health gains. They are benchmarking against NHS, and you can see down the left a clinic that is underperforming. So the chief medical officer at Spire has a clear procedure. Step 1, when there's an underlier, you have the obligation to try to understand first why this medical team is underperforming and encourage them to catch up and enter into a peer-to-peer dialogue with peers. But the second step, if there's no improvement after a trimester, is to reorient patients and to refer them to other clinics. And that's clearly pressure to succeed and improve patient outcomes. My NHS is a web portal that was launched by the NHS. For hip replacement, you can see a very interesting way to present quality of life indicators with risk adjustment. So you have pictograms with the names of the clinics, below average, average, or above average among the best. And you also have risk adjusted hip revision rate for a 30 years period, which is also very compelling in terms of level of evidence. For some reason, the NHS shut down this portal and is working on a new portal to display patient outcomes and nominative benchmarks in a legible manner, so health system users can orient themselves when they are seeking planned care. There is also an interesting initiative in terms of hospital ranking to compare hospitals head-to-head. It's driven by Newsweek, who launched its World's Best Hospital last year. And for the first time, they introduced a new methodology with surveys where providers can report if they are documenting or measuring systematically patient outcomes, and if they are disclosing these outcomes, through which methodology, so they can get upgraded in the ranking or downgraded according to this. So that's also an inflection point in terms of hospital comparison. The third dimension of the matrix is rewarding. You need to first invest and get a return on investment. And the return on investment could be an economic one with remuneration, or a psychological one with recognition. Let's start with investing. There's a classic debate whether you should buy or build a data platform. Well, you have pros and cons for each of them. You have here an illustration of a budget custom-built PROM data platform in the university hospital. So that the cost is significant. Nevertheless, they have full control to customize and update the platform according to the expectations or the evolving expectations of the medical teams. If you purchase, if you buy a license of a data platform on the shelf from an IT vendor, of course the costs are reduced dramatically, and you can start probably more rapidly. Nevertheless, this platform will probably not be easily customized according to the medical team's needs. Now, the payment mechanisms. Well, we have a variety of payment mechanisms. Today, most of OECD countries are working under a fee-for-service system, but there is also the bundle payment, which is probably the solution where value-based healthcare can make difference, since bundle payment incentivizes against over-servicing. Well, today we live in an era where care pathways are hyper-fragmented. You have different steps of the pathway and different fees for each step. If you regroup this in a bundle price, then you will find payers, but also manufacturers or health systems who are willing to shell out the entire care pathway and not to pay upon each intervention. Of course, the purpose is to make each caregiver accountable for the outcomes of each step, so there's no need to blame anyone or to pay for extra payments if there is a complication or a re-intervention. Sweden is a famous case here. We have in the Stockholm region a bundle payment that has been implemented for hip and knee osteoarthritis. The providers are financially responsible for the full cycle of care for up to 2 years after the operation, and you can see after 2 years the stunning results. Patient sick leave dropped by 17%, the cost per patient declined by 20%, and now Sweden is developing and expanding these bundle payments to other conditions, and this is also why Sweden is massively investing in outcome-based registries. The fourth dimension is about improving health gains. This requires improvement cycles, training programs, plan, do, study, act approaches, iterative circles. But it also has an impact in terms of research and the dissemination of medical knowledge through outcome-based registries, which transforms the management of clinical trials. So first, improvement cycles. Well, you have a Dutch illustration of this for rectal cancer. Each dot represents a provider, and the red line is the complication rate. When it's an inverted scale, when the red line goes high, the complications are lower. And you can see that all the dots are regrouped after 4 years. There's a magnetic effect, and the in-hospitality mortality decreased actually by 43% in 4 years only. How was it possible? Well, there was no carrot and no stick. It's just the power of transparency. When an underlier looks and compares itself and detects outperformers, there's a pride reaction. Nobody wants to lag behind in the peloton. Everybody wants to catch up and deliver high-value care. And it happened also in Sweden when in 2006, the Registry for Coronary Care published the Quality Index score. And you can see that the 69 hospitals participating in this benchmark improved dramatically after these outcomes were made transparent. Even the blue line, the below average hospitals, also catched up very rapidly, and the slope of the curve is progressing by 40%, which is also a kind of acceleration to catch up. And this is also why the Ministry of Health and the health authorities in Sweden are massively investing in PROM registries. Still in Sweden, again, the maternity unit has a scorecard. You can see in 2006 that you have many red flags, and after just 1 year, you have also green flags. There's pride. We have improved together, and that's also strengthening the team spirit, since you benchmark with yourself, but you benchmark also with your peers. It's not only hospital-centric. It's not only happening in Sweden. You can see in Denmark, Good Life with Osteoarthritis in Denmark, GLAD. It's a non-profit who actually is developing exercise as first-line treatment to improve functional recovery after surgery. And you can see with this that this network of independent caregivers that are not working in hospitals and clinics, they have actually developed knowledge through an outcome-based registries, and through this registry, the quality of life of their patients improved by 20% after 1 year, and the sick leave dropped by 42%, which has also tremendous impact in terms of societal, for society and health system as a whole. In terms of clinical trials, you have an illustration coming from SWEDISH, the Swedish registry for in cardiology, and you know that there was an ongoing debate about mechanical thrombectomy associated with percutaneous coronary intervention, PCI. So is mechanical thrombectomy effective? Is it decreasing mortality rate? Well, you have two studies. One is a classic randomized control trial on the right, conducted over a 6-month period, and the other over a 42 months period. On the left, this is a registry randomized clinical trial. That means you have a registry with longitudinal measurement of patient outcomes, and on the right, you have a control trial where patients are monitored, where posology is also adjusted, where doctors are controlled for their prescription and co-prescriptions. Well, it's so controlled that to some respect, it's becoming unreal. Whereas on the left, you have a registry trial working on real-world data where doctors are not necessarily prescribing the right dose for the right patient, where the patient is not necessarily adhering to the treatment. There's a lot of noise. And this is why the period of inclusion is longer, 42 months. But at the end, 2 publications in the New England Journal of Medicine, so same level of evidence. Nevertheless, the cost for the randomized control trial is 50 million euros, whereas it's $500,000 for the registry trial. So we need to pay attention to these figures because, of course, you have a setup cost for the registry, which is not integrated in this price. Nevertheless, you can see how rapidly the guidelines evolved over a period of 5 years where mechanical thrombectomy was nearly abandoned. And this is why the FDA and the EMA are now working on integrating these real-world data and registry-based trials for phase 3 in order to not only cut the cost of phase 3 trials, but also generate a body of evidence disseminated through the literature. The last part is about partnering, and this is probably the most interesting one, because this involves multiple players and stakeholders. Through external collaborations, you can partner with academia, patient representatives, life science companies, but you also need internally to mobilize internal forces, not work with one or two isolated cheerleaders, but get also the entire medical team or caregivers supporting the value approach, and get also the endorsement from the board to make sure that this is aligned with the strategy of the hospital. So we found out in the report a series of very interesting and innovative illustrations with Roche, with Amgen in Denmark, with Medtronic, with Mensis, which is a payer who is developing a bundle payment mechanism through capping systems and mirror meetings, and also in France, UniHA, which federates 1,000 public hospitals in order to concentrate hospital procurement tenders, and they recently also worked with 3M, which incurs a penalty if the device fails to achieve expected outcomes. We also found a very interesting and innovative medical device launched by Sivan, an Israeli startup. It's actually a digital biomarker integrated in an electronic patient reporter system, PROM, to telemonitor patient in lung cancer remission. And these type of tools and medical devices are actually changing the landscape of telemonitoring. They are also generating substantial savings, since there is a number of imaging procedures that are avoided because there is routine reporting from patients that enable doctors and caregivers to detect red flags and take action proactively. The central or the cornerstone of this outcome-based ecosystem and this partnership is the third party. We found out nearly 100 of VBHC initiatives conducted last year across the 22 EU countries. Nearly all of them were providers or independent caregivers evaluating their own outcomes. So they were actually benchmarking against themselves. And when one of them is outperforming, nobody knows about it. Even the outperformer is not aware that these outcomes are really impressive. So the idea, and we found some concrete cases that I've just mentioned, where you have open benchmarks, where these providers accept to work on the same agenda with the standardized scorecard, with the same data platform, with the same incentives, with trust that is actually fueled by a learning community. And this is what we have also developed in France for the pilot on cataracts with the Ministry of Health. The idea is to disseminate these outcomes and health gains in a community of stakeholders, practitioners, providers, patients, payers, authorities, academia, manufacturers, and laypersons, with also involved as a health system user. So this is probably the most critical point in implementing value-based healthcare, to steer away from an auto-evaluation and move towards open comparison. And this requires a neutral facilitator. A neutral facilitator that will standardize questionnaires on patient quality of life through academic calibration. For instance, we found out that in in Italy or in France, when you have a PROM instrument, originally this PROM instrument is published in English in the literature. You need to translate it into French so patients can answer the French version of the questionnaire. But you have a translation in Marseille that differs by 1% from the translation in Paris, in Lille, or in Nantes. So actually, this prevents rigorous comparison and benchmark, and the ecosystem collapses because there is no standardized instrument from the beginning. You have also the digital or dematerialized collection of real-world data through without slowing down the activity, and this is absolutely essential. Comparing with or through case mix adjustment to prevent adverse selection of patients. So we have also built up, we have seen, at least for the French illustration that PROM Time has launched with the Ministry of Health, we have fragmented the patient population with case mix that are very severe, intermediate, or not severe. And if one practitioner wants to bias or game the system by treating only the easy cases to have a good average health gain and a good reputation to attract more patients, well, there's no real debate here, since these easy cases will be compared with with the same category from other providers or caregivers. This neutral facilitator needs also to audit the integrity of outcome data. This requires three dimensions, three audits: comprehensiveness, compliance, and reliability of data. We also need to encourage health professionals for high-value care through targeted incentives, could be remuneration or recognition, and sharing the outcomes with a community of stakeholders, all stakeholders, and that's also part and parcel of the challenge of finding a common ground built on trust, with a safe environment and a clear governance to enable the evolution of these rules. So I would like to share a bit of how we apply the matrix described in the EIT Health Report to a concrete case in France with the Ministry of Health, who funded the first VBHC pilot on cataracts with a decree published last summer, who derogates to the common law with actually two innovations. The first is that we are now allowed, or PROM Time is now allowed, to measure patient health gains with case mix adjustment and nominative benchmarks of practitioners. That's completely new. It was not authorized until now. The second thing is that there is a fee for transparency, incentivizing practitioners to share health gains with all stakeholders. It's not a fee for outcomes, it's a fee for transparency. The fee for outcome, or the incentive for outcome, is already here with reputation, with visibility, with attractiveness. So there's no need of a double fee to incentivize according to the outcomes achieved. But we found out through thousands of hours of discussions and negotiations with the practitioners, the payers, that the bottleneck is where the practitioner finally agreed to disclose their average health gains. And there is resistance here. So a 30 euro fee per transparent case is attributed to the practitioner on top of their honorarium in order to overcome this resistance. Now, we went through each step of this matrix with the 9 building blocks, and we eventually started with a scorecard. We used a PROM instrument named the Katz 9SF. It's 9 questions used by the European Registry for Cataracts, which is well established, and it was easy to get the practitioners' adherence to this instrument. So you have on each corner of this spider chart one question asked to the patient about their quality, their visual quality in their daily activities. Can you recognize the faces of the persons you meet from 1 to 4? Can you read the newspaper from 1 to 4? Can you walk on uneven surfaces from 1 to 4? And at the end, you come up with a score, a pre-operative score, that you compare with the post-operative score, and the difference is the health gain, the patient health gain. Here it's 45%, which is excellent. Now, when you compare head-to-head different medical teams, you can see that the blue post-operative score is 3.9 out of 4, which is excellent. And it's equal in Nantes and Limoges to leading medical teams. But when you see the health gain or the clinical benefit, you suddenly discover that it's 34% on the right and 45% on the left. How come? Well, it's because the indication to prescribe surgery differs. It's actually prescribes when the score is 2.9 on the right and 2.6 on the left. So the idea here is to indicate or prescribe a surgery at the right moment for the right patient in order to optimize health gain. We found out in Wales that the NHS published recently, using exactly the same methodology, that 20% of patient health gains were nil or negative after cataract surgery in Wales. 20%. You have, of course, insufficient health gains, such as 5%. It's considered as positive. So we estimated that there are nearly 30% of cataract surgeries which actually deliver low value care. 30%. Why is that? Probably because practitioners or surgeons are prescribing surgeries inappropriately. So in order to help them without patronizing them, is to provide them with a registry in open access so they can learn from the body of knowledge and the data that were collected by their peers and find out when to prescribe in order to get an optimal health gain and maximize high value care. While the collection of data, the patient is admitted to the admission, he receives an identification number, a QR code is printed out, and the patient sits in the waiting room, flashes the QR code, gives his or her informed consent, and answers an auto questionnaire. So go through the 9 questions of the CAT quest, takes 5 minutes, and then steps inside the clinical consultation with the practitioner. And the CROM, so the clinical reported outcome measures, are combined thanks to the QR code with the PROMs. So there's a concrete case, a completed case, that is then collected throughout the care pathway before the first eye, after the second eye. And these data are disseminated in the community outside of the hospital, including independent practitioners such as ophthalmologists or orthoptists, but also pharmacists and opticians. So this is the kind of software we are working with in Nantes. There is another one in Limoges. We have created connectors in order to get a full pure extraction of CROM data. We also have nominative benchmarks where doctors can also click or unclick the disclosure of their own data to their peers. Of course, if they decide to step back and return to opacity, there's, of course, suspicions from peers who are asking, why do you have something to hide from us? But when you compare, actually, you see that these tools are really oriented not to stigmatize, but really to help practitioners to make their own decisions. You can see on the upper histogram in yellow that the bars are actually for high pre-op scores, which is the risk of inappropriate care. When you operate patients that have already a good visual quality, then it's unlikely that you will improve their health gains. And ultimately, you can detect for each practitioner what is the room for improvement in terms of high-value care. Then when you reward the practitioner, you have first a psychological incentive based on reputation. Let me take you through this chart, which seems a bit basic, but actually you will find out that it's very complex. There's two doctors, Dr. Glass, Dr. Black. Dr. Black keeps patient health gain opaque for the community of correspondents, of pharmacists, of opticians, of payers. Whereas Dr. Glass accepts not only to measure in a standardized manner patient health gain, but also to disclose them. So there is 100 patients for each doctor, and there is just one patient that is not operated, that is not undergoing surgery. After 1 or 2 years, then Dr. Glass receives more patients which are referred from the community of professionals. Dr. Black is pretty surprised not to attract more patients, and simply because he operates his activities in darkness. So that's why, without visibility, patients are not referred to Dr. Black. But Dr. Glass has just 2 hands and 1 day at the OR. So actually, he can only perform 90% of surgeries, and there are 10 patients that are not undergoing surgery, and these patients are the result of a triage strategy based on the PROM results during consultations. After several years, eventually Dr. Black decides to convert his or herself to transparency. He or she understands that this is the only way to play by the rules, that not only the patients but the correspondents are also willing, and this is why he's accepting to compete with Dr. Glass on outcomes. And you can see that out of 200 patients, 20 of them are not undergoing surgery. So the idea is that after several years, 10% of inappropriate procedures are avoided, and that's also a significant saving for the health system. It's also preventing some patients to undergo inappropriate care, and that's also part of the problem. Improving. Well, with this body of knowledge, we will perform over 4 years. We will make 25,000 transparent health gain through those sites. We will have a sample size that will enable us to create this kind of chart with prospective optimization of health gain for practitioners. Take the box on the upper left. With a baseline score lower than 3.0, the probability of achieving meaningful improvement is 93%. But on the upper right, with a baseline score higher than 3.5, the probability of failing to achieve meaningful improvement is 92%. So this is also the result of measuring patient health gains and making them accessible to a learning community. Nobody is telling the practitioner what to do. The practitioner should just read at the data and understand that he or she has something to lose or to win in terms of recognition and reputation if they decide to pay attention to what they prescribe for which type of patient, and this will ultimately, hopefully, generate savings for the health system, and these savings could also be reallocated for funding or shelling out innovations. So 25,000 health gains by 2024, and this is financed by the Ministry of Health. We receive a 1.3 million government grant. We've gathered a bunch of parties involved, including the French Academy of Ophthalmology and the French Union of Ophthalmologists. They are sitting on our board. That's very important to make sure that this project will be scalable if successful. And the governance is clear. We have a scientific body hosted by the VBHC Consortium, which is a non-profit in charge of scientific affairs. And we have PROM Time, a for-profit company who's sponsoring the project and managing the initiative under the auspices of the Ministry of Health. So in terms of culture, We've been living until now, until the paternalistic role of the practitioner who's patronizing and also gratifying himself, whereas today with VBHC, the practitioner is evaluated by the patients as well, and there is a kind of humility since it's documented during the classic dialogue between a patient and a doctor. The classic introduction phrase was, how do you feel? And now this is being transformed into, how much do you feel? Because you quantify through PROM measurements, you quantify the health status of a patient and you involve the patient in decision making for the care pathway. Thank you so much for this invitation. I invite you to take a closer look at the EIT Health report, which is accessible online, open access. Thank you.